So good morning. Today's resident lecture will be given by Dr. Adak Astast, who is a first-year resident and a graduate of the Philipps University in Marburg. And her presentation today is going to be about parenteral nutrition in patients undergoing major abdominal operations, which we believe is a topic of interest to most everybody in this room. Please, Adak.
Thank you very much, Professor Turina, also for the supervision. Okay, I would like to give you a quick overview about my talk. So first of all, I would like to talk about what parenteral nutrition really is, the indications and, of course, contraindications, the different possible accesses for administration, the products that we use, also the risks, and in the end, the role of parenteral nutrition in abdominal surgery. Parenteral nutrition is an intravenous nutrition of macro and micronutrients, bypassing the usual process of eating and digestion. Just for those who don't know, macronutrients are carbohydrates, proteins, and fats, and micronutrients are vitamins and trace elements. The indications for parenteral nutrition is to provide support in patients whom enteral feeding is not sufficient in meeting the nutritional goals or the contraindications. Do you know at which point that can be, in which patients? Which patients, where do we have contraindications for enteral feeding, or where do patients not meet the nutritional goals? Can you think of some patients?
An enterocutaneous fistula?
Yes, exactly. So first of all, it can be an anastomotic failure. So there, in this case, we have a contraindication for enteral feeding due to contamination of the peritoneal cavity. As you said, gastrointestinal fistulas that can come up in case of inflammatory bowel diseases. Do you know inflammatory bowel diseases?
Morbus Crohn?
Exactly, and what else?
Colitis ulcerosa?
Exactly, but where do we have those fistulas? When patients suffer from Crohn's disease. Well, it's more likely to have it when you have Crohn's disease. Again, in this case, enteral feeding may increase the drainage, so it would lead to a delay of the fistula closure. In patients where we have bowel obstructions, and also in patients where we have a short bowel syndrome. So if they eat, mostly it's just because of comfort reasons. They don't really absorb anything, so that's why it's good to support them with parenteral nutrition. Of course, we have also contraindications. That is when patients have the ability to receive enteral feeding, and not only to receive it, but to meet the nutritional goal, which is at least 50% of the required calories. And you can have, think about a number of 25 kilograms per day per kilogram. So if you have a person weighing 70 kilograms, it's about 1,750 kilocalories per day. Another contraindication for parenteral nutrition is prior to 5 days, because fasting up to 10 days in healthy patients showed no significant impact on the recovery. But of course, there are exceptions to the rules. In this case, when patients are malnourished prior to surgery anyway. Another contraindication can be acute shock due to the volumetric load and then overload. There are different accesses for parenteral nutrition. So first of all, very common is the central vein catheter. Can you think of others?
You have the PICC line?
Exactly. We can use the PICC line, which is a peripherally inserted central catheter, which is more likely to have less infection or a lower infection rate. You can also use the portacat if the patient has one, or you can use a peripheral venous access in case you intend to have an administration for the parenteral nutrition for less than 10 days. Okay, now to the products. We have different products. First of all, we have the nutrition solution, which is smofcabivin. It contains 50 to 60% carbohydrates, 20 to 25% proteins, and 10 to 20% lipids. You also have the possibility to administer smofcabivin without electrolytes, or to use NutriFlex Special without lipids if the patient has glycerides more than 10 millimole, and NutriFlex Lipid Peri if you want to administer it peripherally. We also have vitamins and minerals and trace elements that can be added to smofcabivin. First of all, we have Cernavit, which is a fat and water-soluble vitamins without vitamin K, and Adavin, which is very useful because due to the infusion of amino acids, we have a higher excretion of minerals and trace elements. Okay, this is actually not a very good slide because there are too many informations on this slide, but I just wanted to show you that parenteral nutrition has a lot of risks, starting with infections, of course, because we have a central vein catheter. We can have anaphylactic reactions due to the fact that we have proteins of soy, peanut, and egg in smovcabivin, which you can be allergic to. Parenteral nutrition in general can lead to atrophy of the intestinal brush border due to disuse because you don't eat or use the enteral route. It can lead to hypoglycemia due to the carbohydrates and increase of nitrogenous metabolites because you administer amino acids, and if they're metabolized, you have nitrogenous metabolites, and especially when you have a renal failure. An important risk that can come up is a fat overload syndrome. That is limited fat metabolism due to insufficient elimination, and it can lead to hyperlipidemia and steatosis hepatis, hepatomegaly with or without jaundice, causing liver failure. And it's important to check the patient's blood results concerning anemia, leukopenia, and hemolysis. You can also have or cause a refeeding syndrome. You have to know in the setting of malnutrition, lipolysis is the main source of energy. And when you start the refeeding, you have an increase of glucose, which leads to, first of all, uncontrolled high distribution of insulin. And as you know, insulin drags potassium, magnesium, and phosphorus into the cell, so we have a low concentration in our blood. The highest risk for refeeding syndrome is within the first 3 days of administration. Okay, so we talked about parenteral nutrition in general, but now we should know what the role of parenteral nutrition in abdominal surgery is. Again, parenteral nutrition is for patients who are unable to meet their nutritional goals using the enteral route. So malnutrition in general is also associated with postoperative complications and an increased risk for death after surgery. So there is a selected group of patients that would benefit from parenteral nutrition, but it's often not possible in practice because they have to be here maybe 2 weeks prior to surgery, and yeah, as you know, sometimes it's very hard to handle. The consequences of malnutrition in surgery can be poor wound healing, increased frequency of decubitus ulcers, and infections due to bacteria in the gastrointestinal tract. As I said, due to disuse, it can lead to atrophy and finally to immune system dysfunction. The problems with handling parenteral nutrition is more or less, there are a lot of studies that have failed to demonstrate a survival benefit, but there are some that showed fewer operative complications and a shorter length of hospital stay. But you have to know that the trials were very small and at high risk of bias because there was no clear definition of malnutrition and also a very broad range of surgical settings, so it's hard to compare the results. Doctors have to work efficient but also economic, so I thought it's maybe interesting to know how much parenteral nutrition costs. Smovcabivin 1.5 liter costs about 120 francs, Atavin about 4 francs, and Cernabit, the vitamins, about 9 francs, just for 1 ampule. But you have to take into consideration that a prolonged hospitalization is even more expensive. Okay, so the perfect timing to start parenteral nutrition. Actually, there is no perfect timing to start with parenteral nutrition, but there is a general consensus based on guidelines published in 2016 by the American Society for Parenteral and Enteral Nutrition and the Society of Critical Care Medicine that says that parenteral nutrition should be delayed at least 5 to 7 days after surgery in the absence of preoperative malnutrition. So patients with chronic malnutrition prior to surgery, of course, should have parenteral nutrition earlier than these 5 to 7 days. Here we have a meta-analysis that was published in 2018 in the European Journal for Gastroenterology, and it dealt with the question if a preoperative enteral and parenteral nutrition reduces the postoperative complications in patients with Crohn's disease. And it showed that the postoperative complications in the group that received preoperative total parenteral nutrition was 15% versus the group that did not receive parenteral nutrition, which had a rate of 24.4%. There was also a group that received enteral nutrition, and it showed that the complication rate was about 22% versus the group that did not receive enteral nutrition, that the complication rate was 73%. So we see that the nutrition reduces postoperative complications, at least in patients with Crohn's disease, but the enteral nutrition is superior to standard of care without nutrition support, with a number needed to treat of 2. And we see a trend for total parenteral nutrition being superior to standard of care, but there is no statistical significance. Okay, so we said there is no standardized scheme for the administration, but actually there are schemes, but you have to adjust it to the patient's need. You can start parenteral after 7 days of fasting with, for example, with smofcabivin, 500 milliliters per day, and increase it with 500 milliliter steps per day. But you have to take into consideration if the patient suffers from that refeeding syndrome until you reach your nutritional aim. And that nutritional aim is depending on what the patient is able to absorb orally and enterally. So as we said, if you have a short bowel syndrome, the patient can eat, but it's just for comfort reasons. If he has a rest small bowel of 30 centimeters, you can assume that there is less time for absorption. So you can support that patient with parenteral nutrition. It's also possible to have the administration for within 12 hours, which is, for example, overnight, and that is really comfortable for the patient. If it's foreseeable that the patient needs parenteral nutrition anyway, as I said, you can start directly after surgery. You can administer either supporting or total parenteral nutrition via a peripheral axis if you intend to administer the parenteral nutrition less than 10 days, and if it's more than 10 days, you can use a central vein axis. I'm repeating myself, but I think it's important. It's depending on the nutritional status measured via the nutritional risk screening. And the nutritional risk screening takes into consideration the BMI of the patient and also the weight loss, which can show the deterioration of the nutritional status. And also, very important, the severeness of the disease that gives information about the stress metabolism. Okay, now about the weaning. You can start the weaning in a patient with parenteral nutrition when you know or when you can assume that the fluid goals are met, and the caloric goals should exceed 60% of the patient's daily requirement. But in cases of extensive bowel resection, for example, short gut syndrome or fistulization, it might not be possible to do the weaning because the patient won't survive without parenteral nutrition due to intestinal dumping and malabsorption, because otherwise it would lead to dehydration, malnutrition, and vitamin deficiencies. Okay, I would like to close my talk with some take-home messages. Again, whenever possible, use the enteral route. That should be preferred because it's physiological. It stimulates the intestinal brush border. And otherwise, if you use the parenteral nutrition, you have, due to disuse, you have an atrophy. And in this case, you have less atrophy. It's less expensive, and there are less complications if you think of infections. Parenteral nutrition should be considered in case of not meeting the nutritional needs by enteral nutrition. It can be supporting or total parenteral nutrition. The indication for parenteral nutrition should be reconsidered on the daily basis, where you have to weigh up the benefit versus the risks. And I think it's most successful if we have the decision-making interdisciplinary with, for example, you as a nutritionist. Yes, thank you.
Yeah, thank you very much for the very nice presentation. I mean, something we use every day, and that's potential for complication and risk and cost. So number one, maybe we have our nutritionist here, so maybe she can try to answer, or you can try to do that. I mean, when I was in the US, that was absolutely regulated. Only one team could give that. So any team, medicine and surgery, had to ask, and the reason was exactly to optimize indication and cost. So here there's a pretty liberal use of this. Everybody can. So the first question is, what should we do? Should we favor that and let everyone and educate everyone, or would be an advantage to have a team or service for the hospital that really look at the indication for this. The other discussion that's the second question we have, is that when the patient is catabolic, usually necrotizing pancreatitis or so, is that really worthwhile to give TPN? Do we have more complication, or do they really can metabolize this nutrition? And the third thing, that I'm just intuitively giving during the night, and so it's nice to look, but we have a circadian cycle, the food are given during the day, so we have clearly some dysregulation, major dysregulation by changing this. Is there any study on that? I know nobody knows. But I mean, these things that we learn, we do for convenience for the patient, but there may be some really important side effects. Ask these questions because I don't have the answer. I don't know if you want to try to answer, whoever knows this. No?
Clearly, we do have nutritional support at the university hospital, or the team can be contacted at any time if there is a need for additional information on parenteral nutrition. Also, there was a clear-cut statement from nutritional support that they're willing to educate residents, doctors who are interested in learning more about the different options that we have available. We do not have a nutritional support system such as the one in the United States, where you just pick up the phone and have people come in and they will take care of all the rest. That is not. The one question I might like to ask is, we have heard about parenteral routes, peripheral routes, and we've had this discussion many times, and we believe that the peripheral route is not as efficacious, and also is not tolerated well by the patient. It leads to a lot of burning sensations in the peripheral veins. Some of them don't tolerate that, and you cannot give quite as much nutrition as you can through a central line. So when are we okay with peripheral feeding? When should we go straight to a central catheter?
She told if you need the parenteral nutrition just for 10 days, or the patient is eating as well, and you just need it to support it a little, you can use the PVK. But otherwise, if you see that he is malnutritioned and he eat nothing, or because of the surgery he can't eat anything, I think I would go to the central line for beginning.
Our policy is usually to use central line. Is only when they leave the hospital and they need it for a long time in some rehabilitation, they don't take this central catheter and we move to the periphery. Usually it'll be the policy we have here, but I don't know if there is any study on that. I am not sure. Is any question or comment?
I don't know if I'm a central line expert, but what you were saying about the central line, if it's a long-term feeding, I would not go for a portacat, I would go for a tunneled central line, so a Broviac catheter or a Hickman catheter. So I would not put in a portacat for long-term enteral feeding.
Broviac versus PICC line?
Well, the PICC line is a good line for 1-2 months, but after 3 months, most of the PICC lines are thrombosed. So for a couple of weeks, it's okay. So if you want long-term, I would go for a tunnelized central line.
Thank you for a nice talk. I have a question. If you have planned 5 days after post-surgery, someone is not malnourished before, or not really major malnourishment, and has planned 5 days that he will not be eating, but we know that we'll start eating after that, for example, after esophageal surgery. Would you start with parenteral nutrition or not?
Well, the guideline says no. The guideline says if the patient is not malnourished, he or she can tolerate the fasting of 5 days.
One question to you, because you did a great talk. There's a lot of guidelines. Do we have any study? Do we have any evidence, randomized control trial of one versus the other one? Because that's a bit my impression that we just talk. We fortunately have people who advise us. The word interdisciplinary is always nice, but here it seems more to me that nobody knows, nobody wants to take responsibility. So we ask 3 people and then nobody is behind this. I'm not saying we should do alone, but what is study? There's randomized control trial?
As I said, there are a lot of studies, but there is no significance, no statistical significance, because the malnourishment of the patient was not clearly defined. And the preoperative situation was very different, so it was hard to compare those results.
Well, I think you're totally right. I mean, some of these are presented, for example, the European Surgical, with very small sample size. If you want to see anything in parenteral or enteral nutrition study, you need thousands of patients. Mm-hmm. And I'm not aware about convincing meta-analysis. I don't know this literature very well, but I don't have the impression we have a high level of evidence, which is a bit surprising. And sometimes it's also driven by pharma. So at the end, they pay the study and they want to sell the product, and this is a major bias in medicine and in randomized controlled trials. So basically, we have a talk, not your fault, it was a very good talk, but without data. Okay, well, so thank you very much. Thank you.